Good day, and welcome to today's webinar, Operative Standards for Rectal Cancer, hosted by the International Relations Committee and the Cancer Surgery Standards Program at the American College of Surgeons. My name is Jessie Von Custer. I'm the Program Administrator for the IRC. Before we get started, I wanted to inform everyone that this webinar will be recorded and will be posted and available for viewing on the ACS YouTube page after this webinar. Additionally, if you have any questions during the webinar, you may submit them through the Q&A box at the bottom of your screen, as there will be a Q&A portion at the end of the webinar. With that, I'm pleased to introduce you to today's moderator, Dr. George Chang. Dr. Chang is the Associate Vice President for Clinical Growth and Site Integration and Professor at the University of Texas MD Anderson Cancer Center. He also holds the Sue and Radcliffe Killam Chair. He has authored approximately 300 peer-reviewed papers and serves on the editorial boards of several journals. He co-led the development of the ACS Cancer Surgery Standards for colon and rectal cancer surgery, and he also serves as the co-lead for the American Joint Committee on Cancer Lower GI panel. With that, I'll now turn it over to Dr. Chang. Dr. Chang?
Great. Thank you so much, Jessie, and many thanks to everyone for joining us today for this ACS International Relations Committee and the Cancer Surgery Standards Program webinar on the operative standards for rectal cancer. Today, we have an excellent group of panelists. We will be hearing from Dr. Nader Hanna, as well as Professor Dakshita Wickramasinghe from Sri Lanka. I will provide an introduction, and then we'll hear from Dr. Hanna. Dr. Hanna is currently the chair of the International Relations Committee at the American College of Surgeons. He's a professor of surgery and chief of surgical oncology, as well as vice chair of cancer services at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia, Pennsylvania. Welcome, Dr. Hanna.
Thank you, Dr. Feng.
To this panel. Thank you.
Yep.
And then next, I also welcome Professor Dax Wickramasinghe, who is professor in surgery at the University of Colombo and an honorary consultant surgery at the National Hospital of Sri Lanka. He has authored over 70 peer-reviewed manuscripts and has research focus in colorectal surgery, including anorectal physiology and simulation-based surgical training. He is a fellow of the American College of Surgeons and the Royal College of Surgeons in England. Welcome, Dax.
Thank you very much.
So now that I've introduced everyone for today, I'm going to begin with a brief introduction. So Jessie, if you could start our first slides. Great. So today we are talking about operative standards for rectal cancer surgery. Next slide. I have no relevant disclosures for today. Next slide. The operative standards for cancer surgery have been highlighted in 3 volumes that include multiple disease sites. And the 3rd volume is broken up by disease site, so there's several sections there. But colon cancer was covered in volume 1, and rectal cancer was covered in volume 2. And I've put the cover photos. They're available through the college, as well as on Amazon and other online sources. So wanted to just share this information with everyone. They're great references for you to go to if you would like to get more detailed information about some of the presentations today. Next slide. So we are talking about surgical treatment for rectal cancer, and we're going to focus on surgical management. In my brief introduction, we will touch base a little bit on the workup, as well as the pre-surgical evaluation, and very, very briefly on pre-surgical treatment, or the rationale of, as well as some initiatives for quality and how we would recommend that the operations be reported in your practice. But as we think about this, the surgical treatment for rectal cancer, it really begins with a detailed evaluation. And it goes without saying, this should include a full colonoscopy, laboratory evaluation, including baseline carcinoembryonic antigen level, as well as whatever blood work, such as a CBC that that helps to provide a safe operation, and then appropriate staging, including a CT scan of the chest, abdomen, and pelvis, and then very critically, a high-resolution MRI of the pelvis. Next slide. I'm going to illustrate this workup with just a couple of cases, and I think by the end of our presentation and presentations and discussion today, we should have a pretty good idea about the approach for these patients. So this is a 51-year-old gentleman who presented with hematochezia, and you can see the endoscopic photo that shows an ulcerated invasive carcinoma. It was located at 7 centimeters. CA was elevated at 4.6, but you can see this locally advanced tumor. And then the MRI photos are shown. I didn't show the CT, but this was a localized tumor, so no metastases distantly. But some key features are identified in these MRI images. In the middle panel, that is a sagittal MRI that demonstrates the tumor located within the mid and proximal rectum. It straddles the peritoneal reflection, and that is a very, very important landmark to determine our treatment, and we'll go over that a little bit more in a minute. And then on the high resolution, cone down axial views, we can see some features of this tumor, including the presence of vascular invasion, the thickening and threatening of the mesorectal fascial margin, although the margin, it's approaching the margin, although what you're seeing here actually is thickening of the anterior peritoneal reflection. So that doesn't, that is not a mesorectal fascial margin. We're going to be hearing about these concepts. And then you can see in the right-hand side an abnormal and irregular and heterogeneous lymph node. So node positive, EMVI positive, peritoneal reflection thickened, but mesorectal fascia around the lateral and posterior aspects are clear. Next slide. This is another case, 38-year-old gentleman who presents with altered bowel movements, and you can see there is an ulcerated mass in the distal rectum. This is an endoscopic photograph from the dentate line, and the patient also has an elevated carcinoembryonic antigen level. The MRI imaging demonstrates a T3 versus T4B tumor with that is approaching the prostate gland and abutting the prostate. We can also see on the right-hand side extensive extramural vascular invasion, as well as a positive lateral pelvic lymph node. And perhaps we might have some time in the discussion to get to talk about that as well. Next slide. So it's very important for us to have this imaging because the surgery is determined by the anatomy of the rectum. And here are just some illustrative examples of MRI. On the left, we can see a sagittal view that pretty clearly shows the anterior peritoneal reflection just above the seminal vesicle that you see on that image. We can see the mesorectal fascia margin posteriorly on the left-sided image, as well as that anal canal very clearly on the left-side image. And if we had other projections, we could see the intersphincteric space as an example. On the right, we see a patient with a tumor that is at the level of the seminal vesicles. And here the mesorectal fascial margin is threatened by the extension of the tumor, the extramural extension, and actually in this particular case, there was vascular invasion that was extending, and it's been marked by that red line, but very clearly the mesorectal fascial margin can be seen on the MR. So the MRI is a critical component to our evaluation, and I think we will be hearing about our technical approach to ensure that we have a complete resection and that we're meeting our oncologic standards. Next slide. So the other kind of piece of managing rectal cancers, now that we have that workup, we see that we have some high-risk features that have been shown, including lymph node positivity or vascular invasion or threatening of the radial margin. So in order to treat and address those concerns, we think about neoadjuvant therapy. And I think to this audience, we don't have to go into the basics of neoadjuvant therapy, but simply to highlight why do we give it? What are our goals? We want to optimize local control. We want to decrease the risk of distant metastasis, and we want to maximize treatment response. These are all things we want to accomplish by neoadjuvant therapy. Next slide. And in so doing, we want to improve survival, we want to improve disease control, and we want to improve quality of life. Next. But while we're doing all of these things, we want to avoid overtreatment, unnecessary toxicity. So next slide. Our current paradigm in the US is one that incorporates neoadjuvant therapy, and generally speaking now, total neoadjuvant therapy. And I've put the NCCN guidelines here. There are variations around the world. One thing that I don't point out, and these guidelines do not specifically point out, is not all tumors are the same. And so that's beyond the scope of our discussion today. But when we are considering neoadjuvant therapy, these are the different approaches. It can include it includes both radiation and chemotherapy. The chemotherapy can follow the radiation, or it can come before the radiation, or it may include chemotherapy alone. And this is what I mean about trying to optimize a treatment and avoid unnecessary toxicity. And of course, nowadays, with this kind of management paradigm, sometimes we're able to defer surgery. And so it's not really possible to talk about surgical management of rectal cancer without acknowledging the importance of all of these different treatment components, because they can facilitate surgery. Next slide. In fact, the benefits of the neoadjuvant therapy are that it can improve local control, improve the outcomes of surgery, induce tumor regression, and improve our technical resectability, and then with TNT, reduce the risk of distant metastasis, and now offer the potential for organ preservation. The next component, excuse me, I just wanted to point out, next slide. One of the reasons and benefits that we have with therapy, and this is very relevant to our surgical management, is that we can improve our ability to achieve a clear margin, a clear circumferential resection margin at surgery. And this is my only data slide. Excuse me. It demonstrates that if we can achieve a clear margin, so the technical standards are important. What we're going to learn in the next couple of presentations are important, because we are going, in so doing, we can clear that the resection margins that improves local control, disease-free survival, as well as overall survival. Next slide. Excuse me. So the importance of these factors are recognized now. And within the American College of Surgeons and Commission on Cancer, the rate of radial resection margin positivity within a surgical unit that treats rectal cancer is now a quality measure. And so all hospitals that are certified by the accredited by the Commission on Cancer now must report the resection margin status, and it is reported back as the unit's margin positivity rate. So it's a real opportunity to ensure monitoring of quality. I'm just going to leave you with one last slide, and you can be thinking about this as you hear from both Dr. Hanna and Dr. Wakaramasinghe. This is a synoptic operative report template that we have that has been published with the Cancer Standards, Surgery Standards Manual, and really highlights many of the factors you're going to be hearing about today, but highlights the important components that allow us to be able to communicate what we did at surgery, and synoptically ensures that all the critical elements have been noted and how they were done have been described. So with that, I look forward to our discussions later on, but without further ado, I'm going to turn it over to Dr. Hanna, who will provide more details in his presentation. Thank you.
Thank you, Dr. Shank. Let me share my screen. You can see my screen?
Yes, thank
Okay,
you.
great. Thank you very much. It's a great honor to participate in this webinar. So my role is going to be talking about the upper standard for cancer for rectal surgery, specifically for proctectomy or low anterior resection, and I do not have any disclosure. So if you look at proctectomy and you look at the critical elements, so it goes into stepwise approach. First, as with any cancer operation, we're going to do abdominal exploration. Then we're going to talk about proximal vascular ligation and appropriate lymph node dissection, the concept of total mesorectal excision and how that's important for improved oncological outcomes. And then what do we do for the distal margin when the tumor is quite distal and for sphincter sphering surgery? And then you're talking about a little bit about how to maintain the anastomotic integrity and decrease the risk of anastomotic leak. And really, the goal here, as pointed out by Dr. Chang, is to reach R0 oncological resection to improve and minimize morbidity and improve quality of life and, of course, overall survival. But in the short term, you need to make sure you have a widely patent anastomosis, which is well vascularized without undue tension to minimize the risk of a leak. And I'm going to talk about some of the factors that might help decide, how you're going to do your anastomosis and what would be appropriate. So let's talk about abdominal exploration. Why is that important? Because unexpected intraoperative finding may alter your surgical and treatment decision making. You're looking for evidence of metastatic disease, which can have a different form. You can certainly be surprised to find ascites, as you see in the picture. You can find peritoneal carcinomatosis that was not visible on the CAT scan, although this one would have been visible on the CT scan or MRI. So the small liver metastases, when they are less than 1 centimeter, you might see them when you explore the abdomen. And of course, and sometimes in the imaging, you recognize that this patient had retroperitoneal adenopathy. We're going to talk about what is the significance of this finding in the preoperative setting. And don't ever forget, in women, you need to look at the adenexal, make sure you rule out adenexal mass in women. Assuming your abdominal exploration was negative, the next step in the technical procedure is to decide where you're going to do your vascular ligation. And it's always been debate whether should you do a high ligation versus lower distal ligation. So it was high ligation. Of course, as you expected, with high ligation, you're ligating the inferior mesenteric artery right at the origin of the aorta. So it's not unusual that you're going to have more lymph nodes to be harvested, which would help to accurately stage the patient. Certainly, there is increased risk, especially in unexperienced hand, of autonomic nerve dysfunction. And certainly in certain patients who have vascular disease or calcified vessels or uncontrolled diabetes, there's a risk of compromising the blood supply to the anastomosis when you take the entire inferior mesenteric artery and there is not enough blood supply reaching out to the descending colon for your anastomosis. Low ligation is ligation distal to the origin of the left colic. Data suggests it's oncologically adequate. It certainly preserves the blood supply to the splenic flexure and the proximal descending colon, so you probably have a better vascularized segment for anastomosis. And certainly it avoids autonomic nerve injury. But really the critical 3 questions that you have to answer: how frequently are the inferior mesenteric artery nodes are positive? If you look at the reported literature, the rate is reported somewhere between 2.7 to 3.1%. So it's not a huge percentage of patients who would have positive IMA nodes. But so the next really oncological question: do positive inferior mesenteric artery nodes affect survival and outcome? So looking at the data, there is no consistent oncologic advantage to high ligation and not associated with any improved overall survival or disease-free survival. But the same data would also show that there was no difference in postoperative morbidity between the high ligation and low ligation. So the next, legitimate question: when should high ligation be considered? If you have the option, when would the high ligation be indicated? Well, there are 2 scenarios. Of course, the first scenario, if you find a patient who has clinically involved proximal inferior mesenteric artery nodes, you absolutely would need to remove these nodes, and you will do the high ligation for 2 reasons. One, for local regional control, because if you left the disease behind, that's not R0 resection, and this patient will have local recurrence. And then, of course, for completed staging. So that's more for an oncological perspective. But you can also do the high ligation because of technical reason. So if you don't have enough length of the colon to be brought down to the pelvis for low rectal anastomosis, you might have to actually, first step before you take down the inferior mesenteric artery high ligation, first attempt, you should divide the inferior mesenteric vein along the inferior border of the pancreas. You have to take it down so proximal to the central drainage from the splenic flexure. So you might have to do it either for oncologic region, if the nodes are clearly enlarged and concerning positive, or for technical reason, if you want to have enough length to provide mobilization of the descending colon down the pelvis for low anastomosis. So the next step in your technical surgical approach is the total mesorectal excision. So we are all about that. What is TME? So what is really TME? What are we talking about here? So TME was actually introduced, the concept TME was introduced in 1979 by Sir Hill. And what that actually involves was total mesorectal excision. And you see in the imaging here, this is a robotic procedure. You're actually performing sharp dissection, and again, a sharp dissection, and this avascular retromesenteric tissue plane. This tissue plane has no lymphatics, has no blood supply, no blood vessels. And when we're doing cancer surgery, we're not doing surgery on the organ itself. We're actually doing the surgery on the lymphatics of the organ. So that concept has to be clear understood. So the cancer surgery is cancer of the lymphatics of the organ. So you start dissection, and you can see on this picture here on the right side, you're looking from top down. This is the instrument over the right iliac vessels, and you can see the completely avascular tissue plane. This tissue plane exists between the mesorectum and the presacral fascia, as you can see here. And when you go distally, you can see that you're encompassing the mesorectal fat, which include the mesorectal lymph nodes. But the key thing in this dissection is you maintaining the intact fascia propria of the rectum. And again, this has to be done on continuity with the mesocolon. So when you expose the inferior mesenteric artery, certainly you can do the lateral to medial or the medial to lateral approach, but you need to be on this avascular plane. Most frequently, the easiest way to reach this plane is to open the peritoneum at the level of the sacral promontory. You just put some traction, upward traction in the mesentery. You squirt it along the iliac vessel, and suddenly you get some air in there, and you see this avascular plane. So this tends to be an easy way to find this real plane. The whole idea of this is to completely resect the tumor associated with the draining lymph node. And this is what we're going to be hearing and talking about the circumferential radial margin. So how do you evaluate that you did the complete TME? So if you see in this picture here, you can see the stitch is right at the inferior mesenteric. This was high ligation because of clinically positive node. But what you see here, you see the mesorectal fascia and the glistening, which reflects the light. You don't see kind of fat creeping out. So you know this is a complete TME. And we're going to talk about what's the oncological importance of this circumferential radial margin. With doing that, you also preserve the superior hypogastric nerve or the autonomic nerve plexus, which if injured can lead to some complication, retrograde ejaculation, and bladder dysfunction. But I can tell you, when you make your dissection in this avascular tissue plane, you are also going to protect and identify the ureter and minimize the risk of any urethral injury. So who should have TME? Which patient with rectal cancer should have TME? Certainly, total mesorectal incision is mandatory when you have a patient diagnosed with middle and low rectal cancer. This patient will absolutely indicate it for having a total mesorectal excision. So the next legitimate question was all this fancy tissue planes and imaging, and I showed you, what is the impact of TME oncological outcome? Because this is really the bottom line. Are we going to influence the local recurrence rate, the disease-free survival, and the overall survival? So looking back in some of the early study, the Norwegian rectal cancer group, what he found that the risk of local recurrence was cut in half from 12% to 6% at 30 months. And 4-year survival was actually improved to 73% from 60%. In this particular trial, there was no difference in an anastomotic leak rate of 10% in both groups, and the mortality was quite acceptable at 3%. Another trial, the Dutch trial, which was the largest back then, the prospective trial, included over 1,800 patients. Before the TME, the local recurrence rate was in the high 20s, mid to high 20s, but was employment of total mesorectal excision. The 2-year local recurrence rate was approximately 5.3% combined, but if you break it down by TME alone, was 8.2%. If TME was associated with neoadjuvant therapy, the local recurrence rate dropped to 2.4%. Again, the operative mortality was 3.5% versus 2.6%, with no significant difference. And anastomotic leak rate was actually also very close, similar between 11 and the 12%. But if you look at specifically, this was a paper published back in 2011, but quite illustrate the importance of the circumferential radial margin. So they looked at specifically at the margin, and its impact on overall survival. This was in about 1,500 patients, and the p-value was quite significant. And looked specifically, so you look at the curve, and you can see that the risk of local recurrence was very high in overall survival when the circumferential margin was equal or less than 1 millimeter. Certainly, when it was somewhere between 5, greater than 5, and less or equal to 10, and greater than 10 millimeter, the survival actually was pretty good. So now we recognize that the circumferential radial margin is the most important margin. Of course, most people will have no issues with the proximal margin because you have enough colon to resect. And we're going to talk about the distal margin in a few minutes. But really, the circumferential margin what determines the ultimate outcomes on this patient. Now, is this really important? Could we train surgeon to do that? So this was a project called the TME project was done back in the late 90s, and they looked at the effective surgical training program on outcome of rectal cancer. And certainly the TME project was compared to the Stockholm 1 and 2 trial. And actually what they found when TME was, the surgeons were trained to do TME, you can see that there was significant reduction in the local recurrence rate from 14 and 15% to 6%. And death from rectal cancer dropped from 15 and 16% to 9%. So clearly, at 2-year follow-up, there was significant difference in outcomes. So let's talk a little bit here about the lymphatic drainage of the rectum, because tests tend to be confusing, and because there is some difference in the staging between the US and some Asian countries. So I'm going to focus, of course, is the staging that we use in the US, which is the HACC. So with this illustration, you can see here, I named the blood vessels, the inferior mesenteric artery. You can see as number 1, the common iliac, external iliac, internal iliac was the obturator artery, and the nerve, you can see it coming together. And then you have the middle and inferior rectal artery, and then the internal pudendal artery. So the lymph nodes group, they are color-coded, and they're also numbered. So if you go A, that's the inferior mesenteric lymph node. B are the common iliac lymph node. C are the internal iliac lymph node, if you can follow me on the diagram. D are the external iliac. E are the obturator lymph node. F are the mesorectal or perirectal lymph node. G is the paraortic lymph node, and H is the superficial inguinal lymph node. So the regional lymph nodes for the rectum, based on the current staging system, are the inferior mesenteric lymph node, internal iliac lymph node, the obturator lymph node, and the mesorectal lymph node. Now, of those group, the internal iliac lymph nodes and the obturator lymph nodes are called the lateral pelvic lymph nodes. The nodes that, other nodes, the common iliac, so the paraortic, the common iliac, the external iliac, and the superficial inguinal lymph nodes, they are considered as systemic lymph nodes. This is a stage, they are M1A disease, and they are stage 4A. So I just want to leave the image here for a second so you can grasp and understand, because now we're going to start talking about the specific group of lymph node. Now, as a surgeon, even though you will get a report of the MRI, it is imperative that you, as a surgeon, know the cuts of the MRI and you know what to look for. I'm not going to go through this, but Dr. Chang already alluded to some of the sections you need to look at. Primarily, there are three plane that you need to look at. The one that I'm going to focus on is the oblique axial plane, because this is the plane where you want to look at for the mesorectum, the lymph nodes, and the circumferential margin. I put the reference here. I think this is a great article for surgeons to educate themselves about the MRI for rectal cancer. But again, if you want to look at the node and the circumferential margin, it's your oblique axial plane that will give you the most of the information. And I would encourage all the surgeons that treat rectal cancer to be knowledgeable about the MRI, because you, as a surgeon, you're in the operating room, you know where the cancer, you have great experience where you can correlate your intraoperative finding, the MRI, and I think it's a self-teaching role that you can actually do for yourself, and it's very beneficial. Because I can tell you, as you become expert in this, you're better than some other imaging readers who would read the MRI. So what are the type of lymph node dissection? So the standard lymph node dissection with the TME includes only the two groups, the inferior mesenteric and the mesorectal lymph nodes, as you can see here in the diagram here. The challenge here and the controversy comes in the lateral lymph node dissection. The lateral lymph node dissection include dissection of the internal iliac and the obturated nodes, which are outside the standard TME surgical plane. Now, in some Asian country, the lateral lymph node dissection would also include the common iliac, but just for the sake of discussion, in the US, the lateral lymph node dissection includes the internal iliac lymph nodes and the obturator nodes, which are, again, they are outside the standard of the TME tissue plane. This is, an image from this article that looks at, and I think it looks like it's a robotic procedure, because this is what the view you would see when you do the robotic lateral lymph node dissection. The bottom one is before they dissected the lymph nodes, and you can see the relationship of the obturator artery and nerve. And then the top panel is after they completed the lymph node dissection, and you can see, again, all the neural tissue that encompassed the internal iliac and the obturator nodes have been dissected. So the lateral lymph node dissection is controversial, at least in the US, and actually there is no standard international guidelines for who should have it. Different countries and different society might have their own, but there is no unified international guidelines. Of course, as you would expect with lateral lymph node dissection, there is increased OR time. There is a risk, certainly increased risk of bleeding and or nerve damage. From my own personal experience, robotic really, in my opinion, provides great exposure and very pristine dissection. But again, this is not available for most people outside the US, so you have some challenge there. Now, just to point out, some rectal surgeon might ask the assistance of urologist or GY oncologist, because they also do lateral lymph node dissection. But just let me tell you, the lateral lymph node dissection is a little bit different because the lateral lymph node dissection mostly include the external iliac and common external iliac and some proximal internal iliac, so not necessarily the obturated lymph node. So if you're going to ask some of your colleagues to help you do that, just be aware of that. My recommendation is you probably should refer the patient to a high volume center who have the expertise in doing lateral lymph node dissection. Of course, as we talked about, when you do lateral node dissection, it has to be nerve sparing. You cannot compromise the obturated nerve. So there, what is considered as abnormal lymph node? So there are several reports, but the two main reports that I'm going to focus on is the Lateral Node Consortium study and the Snapshot Rectal Cancer 2016 study, which is actually looked at cancer patient in 2016, but it was actually published in 2022. What the two paper would agree on, that the predictor of lateral recurrence, local lateral recurrence, was the short axis of the lymph node was a size equal or greater than 7 millimeter. Okay, so again, that's important. When you look at the size of the lymph node, it's the short axis that matters, and it's equal or greater than 7 millimeter, which is the predictor of the lateral lymph node recurrence. If you look at the rate of lateral recurrence after chemo-RT, neoadjuvant therapy, and TME, you'll find that the lateral node consortium study, the 5-year survival recurrence was 20%, dropped to 6% after 3 years with selective node dissection. In the snapshot rectal cancer study, the 3-year recurrence rate was 11%, at 4 years it was 15%. Interestingly, both reports showed no associated, that the recurrence was not associated, sorry, the lymph node, lateral lymph node was not associated with increased distant metastasis rates. The snapshot rectal cancer study also pointed out that the morphological criteria, which include the irregular border, loss of fatty hilum, and heterogeneous signal intensity rather than oval shape, might also be a risk in an intermediate sized lymph node in the short axis measuring from 5 to 6.9 millimeter. In this patient, the risk of recurrence increased from 2% to 8%. The summary of this one was that it should not be performed, should only be performed for high-risk patients who have persistently enlarged lateral lymph nodes after neoadjuvant therapy, and in patients who have this pathological node and not receiving preoperative chemo-RT, and really, again, stressing the fact that should be performed by surgeon with expertise in performing that procedure. It's important, that's important to clear the lymph nodes and preserve the neurovascular bundle for that. Just point out to a trial that's ongoing. This is an international prospective non-randomized trial that includes all patients with rectal cancer and at least one lateral lymph nodes that's measured equal or greater than 7 millimeter in the short axis. This patient go on to receive standardized chemo-RT, and then if they have persistently enlarged lateral node after chemo-RT, then they would be recommended for going lateral lymph. They would have under lateral lymph node dissection. The primary objective is to, again, to reduce the lateral recurrence rate from 20% to 6%. So we'll be looking forward to the result of this trial. There's a secondary objective looking at this patient with the intermediate node. This patient will be considered for a lateral node dissection, but it's not recommended, just considered, but not highly recommended. So this is a trial we'll keep an eye on and see what the outcome is. I want to talk a minute about the extra-regional lymph node. So as I mentioned earlier, extra-regional lymph node involvement include the para-aortic, the common external iliac, and the inguinal lymph nodes. They are category M1A, stage 4A disease based on the ACS current staging system. There's not a lot of data in particular, but it's highly recommended from expert opinion that targeted resection and the absence of extranodal disease can be associated with improved survival, very similar to oligometastatic liver disease. So if you identify this lymph node and certainly have the expertise to be resected, again, without evidence of extranodal disease, you may want to consider them for targeted resection. This is, I thought this was an interesting paper. They looked at specifically an inguinal lymph node. And as you know, this is a representation. They looked at all consecutive patients who have rectal adenocarcinoma with synchronous inguinal lymph node metastasis or within 1 year. And they underwent curative surgery. You can see this was over quite a long time period frame from 2002 to 2020. But what they found is interesting. The median overall survival when there was synchronous lymph node metastasis was 75% compared when it was synchronous, but also presence of distant metastasis present as well. So you can see the significant difference in the median overall survival as well as the recurrence-free survival. So the point here, again, this is not, you could debate a little bit, but this patient warrant consideration of treatment with curative intent. And again, if it's isolated inguinal lymph node metastasis without other site of metastasis or metachronous metastasis as well. How about what is the significance of external iliac lymph node versus the lateral lymph nodes? We know that the external iliac lymph nodes from different observations did not result in increased risk of lateral nodal recurrence, regardless of their size. The size here didn't make a difference. However, the presence of external iliac lymph nodes is a sign of systemic disease, and this patient had twofold increase in the distant metastasis. So external iliac lymph nodes are more indicative of advanced systemic disease and not necessarily regional disease. Internal iliac and arterial lymph node behave as regional disease with increased risk of local recurrence. So this is just a difference between the external iliac lymph nodes and the lateral lymph node. How about the distal margin? What's the risk of local recurrence of your margin? Distal margin is positive. Well, it can be approaching as high as 60%. So nobody wants to leave the operating room with distal margin. But the next question is, what's the optimal distal margin for proximal rectal tumors? These are tumors where definitely there is room for sphincter preservation. In this situation, you would do a limited tumor-specific mesorectal excision with a distal mesorectal margin of 4 to 5 centimeters, centimeter of the mesorectum. How about what's your distal margin for mid or low rectal cancer? Okay. So for those patients treated with neoadjuvant therapy, you would need to absolutely consider TMA, which should be really the standard, and a 1 or less centimeter of distal bowel wall margin in sphincter preservation surgery. So there are several papers in here, but I'm going to focus on one recent publication, which is actually, it's currently in press. You can see it online. I think it's released online. And this is specifically looked at the impact of distal resection margin on survival after tumor-specific mesorectal excision for rectal cancer. This included 268 patients. Median follow-up was 27 months. And they looked at the different groups, whether it was less than a centimeter, somewhere between 1 to 0.9 centimeter and greater than 5 centimeter. And what they found out that the 3-year overall survival was 93%, 97%, and 100%. P-value was not significant. And similarly, with the disease-free survival was again non-significantly different. So if you look at the multivariate analysis for this paper, it did not identify distal margin as an independent risk factor for overall survival or disease-free survival. Again, going back to that, the most important margin here is the circumferential margin, and then when it's involved, it's an R1 resection, and there's a significantly associated with disease recurrence. And so this is again speaks to the importance of doing the total mesorectal excision and in the right tissue plane. Subgroup analysis showed no significant impact of the distal rectal margin on survival of patients undergoing the adjuvant therapy as long as it's negative. And the last set of slides, I'm going to talk about minimizing the anastomotic leak. So some of the things here that I think would help minimize the risk of an anastomotic leak is certainly a correction of any modifiable risk factors, importantly nutrition, hemoglobin A1C to be equal or less than 5.7, hemoglobin equal or greater than 11, and of course abstain from alcohol and smoking for at least 4 weeks. With mechanical bowel prep, its oral antibiotics are important. At least in the US, several studies have shown that this contributes to a lower leak rate. Pre-op prophylactic antibiotic, and of course, the most important part is the surgeon and technical. As a surgeon, you really need to know your experience and your personal leak rate. And of course, you need to, we talked about adequate mobilization, no tension, and preserved perfusion. And one of the most important aspect of minimizing the risk of an anastomotic leak, especially in distal rectal cancer, especially after neoadjuvant therapy, is doing the leak test, which I'm going to talk about in a second. What have not shown to really affect the outcome of an anastomotic leak is using drains or mental flap or anastomotic reinforcement or using intraoperative endoscopic evaluation. There is one issue is currently in debate, microperfusion, fluorescence imaging. While earlier reports didn't support any effect, there's some new data coming out, but I think it's not mature enough. So this is still to be kind of the in-between category, whether it will eventually make a difference or not, but at least it's not currently in routine use. So we had 20 studies included for analysis. Intraoperative leak tests ranged from 1.5 to 24.7%. If the leak test was positive, your anastomotic leak rate was 11.4%. If it's negative, it was 4.2, and it was actually statistically significant. And when you have a positive leak test, what do? You do not do suture repair. Your anastomotic leak rate is actually 12%. You either do diversion or revision. So a leak test is an important part, and with that, thank you, and sorry for my voice a little bit hoarse. I went a little bit slower, but thank you for the opportunity to present the data. Thanks, Dr. Sean.
Thank you so much for that very comprehensive overview. And without further ado, I'm going to turn it over to Dr. Dax, who will review abdominoperineal resection. And hopefully we'll have a little time at the end for questions. Dr. Dax.
Thank you, Professor Chang, for that introduction. And good afternoon, ladies and gentlemen. I'd like to thank the ACS for this opportunity. And I would be focusing on abdominoperineal resection for rectal cancer. Next slide, please. These are my conflicts of interest, but nothing pertaining to this lecture. Next slide, please. And these are the areas that I would be focusing on in the next few minutes. I'd like to emphasize that an APR is not an extension of the AR because we have poor outcomes, and I'll be looking at the potential reasons. I'll also look at the types of different APRs and their indications, the oncological outcomes, doing it prone versus supine, the role of the pelvic peritoneal closure, and the options for pelvic floor reconstruction. Next slide, please. And when we speak about the operative standards of APR, it's important to step back and reflect how far rectal cancer surgery has progressed. Less than 50 years ago, the dictum was to offer an APR for any tumor that was palpable on rectal examination. And the dissection was necessarily blunt. And this blunt dissection was advocated well into the 1990s. So maybe in 10 years' time, some of the things that Professor Hannah and I have said today will also be looked upon as heresy. Next slide, please. The Roulier classification is a very useful tool to objectively categorize low rectal tumors. With the continuing refinement of surgical technique, Roulier type 4, which is invasion of the external sphincter, remains the only definitive indication for an APR. Next slide, please. But this study also showed that patients who undergo an APR have worse outcomes compared to all other procedures. Next slide, please. This high local failure rate and the poorer overall survival have remained the bane of the APR. And that's why it's important to not look at it simply as an extension of an anterior resection. But this is also the wrong way to look at these results. Next slide, please. Because when we reinterpret these results as a function of the distance of the tumor from the anal verge, a different pattern emerges. And we see that these poor outcomes are in fact associated with low tumors. Next slide, please. A significant contributor to this is the inability of the classical APR to maintain an intact mesorectal envelope. If you continue your abdominal procedure as for a TME that Professor Hannah described earlier, and if you reach the pelvic floor abdominally, you will invariably cone at the level of the levator. Next slide, please. And this problem is multifactorial. In the lower rectum, the mesorectum is devoid of fibrofatty tissue. The fascia propria is thin and it is fused with the presacral fascia at S3. And given the position of the rectum in the lower pelvis, you need significant traction to expose the anorectal junction. Next slide, please. So how do we overcome these problems? The modern colorectal surgeon needs to familiarize themselves with 3 types of APR procedures to accommodate different needs. In the line diagrams on top, the blue lines represent the abdominal part of the surgery, and the red lines indicate the perineal part. Next slide, please. These images are from the Operative Standards textbook and show the 3 dissections overlaid. And the image on the bottom right shows the extent of the perineal procedure. Next slide, please. And these are the indications for the 3 different types of APR. You would consider an intersphincteric APR when the tumor involves the internal sphincter, or when you would want to avoid a low pelvic anastomosis. An extravagant APR is what you would be performing most of the time and can be used for tumors that are within a centimeter of the dentate line or when the CRM is threatened. An ischial APR is done in locally advanced cancers that are infiltrating the levator muscle, the ischial fat, or the perianal skin. Next slide, please. In an intersphincteric APR, the pelvic dissection is identical to an anterior dissection. You mobilize the rectum with an intact mesorectum down to the pelvic floor and onto the puborectalis. The perineal dissection follows the intersphincteric plane up to the puborectal sling, where you enter the peritoneal cavity. Next slide, please. In the extravagant APR, previous slide, Jesse. Yeah. In the extravagant APR, the pelvic dissection stops dorsally at the sacrococcygeal junction, anterolaterally just beyond the inferior hypogastric plexus, and anteriorly just below the seminal vesicles in the men or the cervix in a woman. This allows the mesorectum to be attached to the levator muscles. The perineal dissection then continues outside the external sphincter up to the levator muscles on both sides, and then you trace the levator muscles onto the pelvic side wall. Next slide, please. And for anyone that cannot remember their pelvic anatomy, the inferior hypogastric plexus is the one indicated by number 6 in this cadaveric dissection, and you should stop your abdominal part of the dissection at this level. Next slide, please. So the extravagant APR, through this mechanism, avoids coning at the level of the pelvic floor, which is where tumor is going to be. And this overcomes a principal problem of the traditional APR. Next slide, please. The ischial APR, the pelvic dissection, is identical to your extravagant APR. But the perineal dissection is much wider. It's carried along the fascia of the internal obturator, and the fat in the ischial space is resected en bloc with the levator muscle. And depending on the requirement, this can be performed unilaterally. Next slide, please. So you may do an ischial APR on one side and an extravagant APR on the other. Next slide, please. If you're able to follow these steps, pooled data reveals that compared to a standard APR, the extravagant APR can reduce your intraoperative tumor perforation. Next slide, please. Your local recurrences, and without a difference in your margin positivity or wound complications. Next slide, please. And next slide, please. Thanks. The next consideration when performing an APR is whether to perform the perineal procedure in lithotomy or prone positions. Well, there's no difference in local or distant recurrence or survival. But there are advantages in the duration of surgery and blood loss when it's performed in the prone position. One thing that must be highlighted here is that irrespective of the position, the governing principle here is to dissect the levator entirely off the attachments to the pelvic side wall. Next slide, please. And that completeness in dissection is what matters most. The key is a wide division of the levator with an en bloc mesorectum. Next slide, please. Once you've completed your resection, the next decision is whether to close the pelvic peritoneum. There is limited literature on this, but at least the results of this study indicate that imaging evidence of small bowel descent as well as small bowel obstruction is less when closing the peritoneum. The upside is that it only takes 10 minutes, and it's an excellent exercise for a trainee to practice laparoscopic suturing. This does, however, close off the true pelvis with the potential of seroma formation and infection. So I myself don't do this, but if you do this, a drain in the pelvis is a must. Next slide, please. Once the resection is complete, the next major step is the reconstruction of the pelvic floor. For the classical APR, as well as an intersphincteric resection, primary closure is adequate. This is also true for many of the extralevator APRs. When the resection is more extensive, like an ischiorectal APR, you need to look beyond primary closure. Broadly speaking, these options could be flaps or meshes, and there isn't a lot of evidence on this for an APR. The little evidence that is available indicates that there is no difference in mortality, post-operative complications, or perineal hernia. Next slide, please. An omentoplasty is an excellent low morbidity option. It fills the pelvic dead space nicely, prevents the small bowel from becoming entrapped within the pelvis. It acts as a barrier in the case of a perineal wound dehiscence, and it prevents fluid collection within the pelvic cavity. Next slide, please. And thank you. I'll be happy to answer any questions you may have on this.
Well, thank you both for your really great and insightful presentations. We don't have unfortunately much time left here for questions, but for those of you who are on the webinar, if you would like to email your questions, send them to Jessie. I'll turn it over to her in just a second, and she can provide details on how to do that. We can collect them and then get the responses back to you. But hopefully all of you have in attendance have had now the opportunity to hear about the operative standards to ensure that we achieve our oncologic goals at the time of surgery for rectal cancer. And as I mentioned at the outset, for more information, please refer to those operative standards manuals that have been produced. So with this, I'll turn it over to Jessie.
Thank you so much, Dr. Chang, as well as Dr. Hannah and Dr. Dax for your presentations. As a reminder, today's webinar has been recorded and it will go on the ACS YouTube site once it is recorded under the webinars for global surgery community. This is actually part 3 of our collaboration with the CSSP program. You can also view colon and breast on that website. We also like to remind everyone that residents can enroll as ACS members for free. So this is a great opportunity to take advantage of all ACS programs, both from the Commission on Cancer as well as General ACS. As Dr. Chang mentioned, this was one of the chapters covered in the Operative Standards for Cancer Surgery manuals. On this slide is information about the product, including links for the chapters. And of course, if you want to connect with the Commission on Cancer, you may do so through their social media, or you can email the CSSP program directly. Lastly, if you have any questions for our panelists or questions about this webinar, as well as the IRC's Global Surgery Webinar Program, you may contact me. My email is on the screen. Or you can also contact us through our social media as well as our email. And again, thank you everyone so much for joining us on today's webinar. We hope that you have a wonderful day. Bye-bye, everyone.